My name is Tanya Hyde, and I'll be moderating today. We also have Anne Gillespie, who works here at CIRPD with me, and she's going to be helping me collect the questions and answers for the end of the program. And our presenter today is Dr. Catherine Bushnell. Dr. Bushnell is the Harold Griffith Professor of Anesthesia and Professor in Dentistry and Neurology at McGill University. She is president of the Canadian Pain Society and treasurer of the International Association for the Study of Pain. Dr. Bushnell won the Frederick Kerr Award for Basic Research in Pain from the American Pain Society in 2003 and the Distinguished Career Award from the Canadian Pain Society in 2002. And in 2009, she was awarded a Senior Canadian Research Chair in Clinical Pain. We're very excited to have you here, Dr. Bushnell, and I'm going to hand it on over to you.
Thank you very much, Tanya. Can you hear me okay?
Yes.
Okay, so this is my first webinar, so I hope I'm not used to talking to my computer, so I hope this all goes well. And Tanya had asked that I try not to speak too fast. I have a tendency of speaking fast, so and you can always tell her that I'm speaking too fast, and she can scream at me if there's a problem. Okay, so I am a basic researcher who studies pain. I'm not a clinician. I don't treat patients. But for many years, I've been very interested in how psychological state affects how we feel pain. And I'll be talking about that today, as well as going a little bit into what we've found. A lot of the work that I do is with human brain imaging, of imaging the brains of patients or other people as well, and looking at how chronic pain can in fact affect your brain in addition to how you can affect your pain. So I'll start off that pain is a very complex experience. It has both sensory components and emotional components, and various people experience pain differently. Now, this man at the left, he actually has a genetic disorder in which he doesn't experience pain at all. And he was in a circus, and he was called the human pincushion, and he could stick needles or anything through his skin and not feel it in the same way as the rest of us would feel it. On the right is normal children seem to experience pain quite vividly, even if you look at the little boys behind the girl, even if they're not getting the needle themselves, they seem to be in pain. So there's a huge range, and in addition to these genetic differences, which I won't be talking about today, some people are just better able than others to control their pain. And we even see this in different societies, and that there are people that seem to be much better able than others. So this painting of the headache, this is what many people, including myself when I experience migraines, feel like. But then there's others, like this gentleman here, who can hang himself from meat hooks. He doesn't have a genetic disorder. He has the same pain system as you or I, yet he is able to control his pain and not have the same emotional reactions to the pain as many of us would under these circumstances. And as I said before, that we use imaging of the human brain, different types of imaging, but mainly magnetic resonance imaging, MRI machines, to look at what's happening in people's brains when they're experiencing pain, and more specifically in these cases when they are using various psychological methods to control their pain. And so we can actually see the representation of the experience that the person is having when they have the pain. Well, I'm not going to go into great depth about physiology, but I just need to give you an overview before we get started with my data, is that there are many parts of the brain that are involved in how we feel pain, and other parts of the brain that are involved in how we can change the way we feel pain. So in terms of the way we feel pain, there's a whole system from that when you have the nerves in your skin send messages to the spinal cord, and then from the spinal cord up to various parts of the brain. And you can see here there's a very complex network that's activated in response to something as simple as stubbing your toe will activate this whole system. And when you have chronic pain, the same system can be activated. Now, in addition to this, what we call this afferent pain system, we have other systems in the brain that help us alter our pain, and we call these descending modulatory systems. And they start up at the top of your brain in your cortex, and they send messages down, and actually all the way down to the point where the pain message comes in to your spinal cord, and they're sending messages downwards that can either lead to the enhancement or a suppression of the message, the pain message that's then going back up to the brain. So through these systems can either augment your pain or they can decrease the pain. And the trick is to learn how to use these systems to decrease your pain. So if you look at, I just want to show you some of these images that you'll be seeing. So these are pictures of the brain when you do MRI, and then you can look at the anatomy of it, and shown here in gray, where you have this stuff on the top is the cerebral cortex, and these little colored areas are where we find this just color representation of where we're finding activation in the brain, where there's neurons and nerve cells in the brains that are active in response to a pain stimulus. And we find that there are parts of the brain that we believe are important for the actual sensation, so that, say, if you burn yourself, the burning, stinging, aching sensation of the burn, and these are the somatosensory areas, or in other parts of the brain that are important for the emotions that we feel, the distress we feel when we have pain. And these are parts of what we call the limbic system, the cingulate cortex, and the insular cortex. And so both emotional areas of the brain and sensory areas of our brain are activated when we experience pain. And these different parts of the brain have differential roles in the experience. And this somatosensory cortex here, this is what primary somatosensory cortex and secondary somatosensory cortex. But this somatosensory cortex, there's different types of evidence that shows that these regions are important for the pure sensation of pain. And one type of evidence, one way that we've learned this, is through people that have had damage to their brains because of strokes. And I'll show you an example here. So this is a patient that had a stroke that led to this white glob here is down an area where there's been damage to the neurons in the brain, and here and here. And these areas are this primary somatosensory cortex and the secondary somatosensory cortex. And so this person has had damage to this areas that we think is involved with the pain sensation, but not to the areas that we think are involved with pain emotion. So what the doctors did when they were testing this patient is they blindfolded him, and then they did various things where they would either pinch his toe or put a hot stimulus on his leg or his arm, or that they would put ice on him. They would do different things in different parts of his body. And he was not able to tell them, he didn't know, he was blindfolded, so he couldn't see what they were doing, and he wasn't able to tell them where the pain was coming from. But whenever they would do something that would, for you and I, would produce pain, he said, "Oh, I don't like that. It feels bad." He didn't know if it was burning or pricking or cold. He couldn't tell any of that. All he could tell was that he didn't like it. And when they would put something on his skin that wouldn't cause pain for us, he said, "No, that doesn't bother me." So all he seemed to have was the emotional reaction without being able to tell anything about the sensation. So he had pain emotion without pain sensation. So it suggests that these parts of the brain that where he had damage were important for the sensation, and these other areas of the cingulate cortex and the insular cortex that we also find activated are important for the pain emotions. So as I said, they have this descending system that we think that can change, augment, or suppress the pain input when it goes up into the brain. And what I want to talk about today is how our psychological state, naturally occurring things, our emotional state, our attentional state, if we're distracted, if we're in a bad mood, how these things can activate these systems and alter the way we feel pain. Now, this is me. I love rock climbing. I've been doing it for 30 years, and so this is me coming up the rock face. And it's one of those things is that where I really, it's my most salient example of how attentional state alters pain. So when you're climbing rocks like this and they're rough and it's easy to scratch yourself or cut yourself or bang your knee or get a bruise, when I'm focusing on my climbing and really focusing on what I'm doing, I don't feel any of it. And it's only when I get to the top of the mountain and I sit down and I look around that I see that I've cut myself or I've bruised myself. But at the time, I didn't feel a thing. I mean, it was like total suppression of something that normally would be painful. And in a smaller way, you just think in your everyday life, if you're sitting at your computer working on something and you're really concentrating on what you're doing, and maybe right now, I hope you're concentrating and you're looking at the screen and listening to me, you may not really think about you may not be experiencing pain at that moment. Then you stop and you take a rest and you realize, oh, I've been sitting in an uncomfortable position, my shoulders hurt, my back aches, but you didn't feel that at the time you were really concentrating, focusing on something else. So it's very simple, but in fact, it's a very important system in the brain and can have a profound effect on pain. Now, the other general system that's very important for pain are your emotions, your emotional state. I'm not sure I believe this, but everybody says, oh, well, when you're giving birth, it's such a wonderful experience that, it's not as painful as it would be. Well, I'm not sure if that's all true, but it's a classic example that when you're feeling good, you're feeling positive, that you can have less pain than when you're feeling bad. And on the other hand, let's say if you really have mixed feelings about getting vaccinations and you're not sure they're good for you, but you think you should get one anyway, then something that is a minor insult to your body could be very painful. So I want to show you today that there is evidence that emotions and attention control pain in very different ways. So when you're in a depressed mood, like this little guy here, maybe has social rejection, which is one of the things that makes you feel really bad, or you're focusing and you don't know what's going on around you because you're focusing your attention elsewhere, that they have different effects on the way you experience pain. So in order to explain this, I first want to explain how we measure pain in the laboratory, or even how we measure clinical pain. And many of you may have had people give you what we call visual analog scales, and you just have a line, and one end of the line, it might say no pain, other might be tolerable pain. But what we generally do in the laboratory is we divide pain into two dimensions. That is the sensation dimension. So no pain sensation, no aching, burning, stinging sensation, up to the most intense pain sensation that you could tolerate. And then on a different line, we have people rate how much the pain bothers them. Was it not at all unpleasant, or was it extremely unpleasant? So we can like poke you with a little needle, and then you rate it, and you might say, okay, well, that pain was about here on the sensation. I felt a little pricking sensation. But on the unpleasantness scale, I really didn't like it. It really bothered me. So it bothered me more than I felt that it was intense. So when you measure that way, then we are able to get an idea about both the emotional dimension and the sensory dimension of their pain experience. And we find, using those double measures, that attention and emotion alter different dimensions of pain. So I'm sorry, this is not very clear a picture, but basically here we have the pain score, and we have this intensity dimension, and we have the pain score on the unpleasantness dimension. And when we have a person focusing on their pain, you see that they're on the pure intensity of the sensation is a lot stronger when they're focusing on the pain than when they're distracted from the pain, and this is significantly different. It goes down from a score of about 8 to a score of about 6, which actually is similar to if you gave somebody a clinically significant dose of morphine would do about the same thing. On the unpleasantness dimension, it goes down a little bit, but it's not significant, and in our studies, it's always much stronger. Attention alters the perceived sensation much more than it alters how unpleasant the pain is. Now, on the other hand, emotional state seems to alter how much pain bothers you, how unpleasant it is, without changing how intense the sensation. So you still feel the sensation. So here we put people in a good mood or a bad mood. We use different techniques. Sometimes one of the best ways for putting a person in a good mood or a bad mood is to give them odors that they like or don't like. And if you're sitting in the presence of an odor that you really like, it puts you in a good mood. And but what we find is that changing a person's mood alters how unpleasant the pain is, but doesn't change the intensity of the sensation. So here we have two different things, attention and emotions. One alters one dimension of pain, one alters the other dimension of pain. And when we look in the brain, we find data that are consistent with what people tell us in terms of their perception. When you look at attention, you have a person, this is your brain, when you're focusing on pain, this is somatosensory cortex. This bright blob here shows that there was quite a bit of activation when we gave this person a painful stimulus. We put a hot stimulus on the person's arm, and we get a nice big activation in the primary somatosensory cortex when we have the person focusing on that pain. When we distract the person from the pain, have him do something, another task so that he's not paying attention to the pain, you see that this bluer as opposed to the bright red is a coding showing that there's less activation when the person, with exactly the same pain stimulus, the same heat stimulus on the arm, but in this case the person is distracted, and we get much less activation in the somatosensory cortex during distraction when the person is focusing on the pain. So this exact same stimulus, and this is true whether it is your clinical pain or experimental pain, when you're focusing on it, when you're thinking about it, there is an enhancement of the activity in the brain. So it's not just that it's not that the activity is always there and you just pay attention to it or not. It actually changes how much activation there is in the brain. And this is like really important when you think about things like your family life. There's been a nice study in Germany where the researcher Herta Flor, she looked at chronic pain patients who had very solicitous spouses, and spouses who were always asking, saying, "How are you doing today, honey? How is your pain?" And it turned out that those patients had more pain than patients whose spouses tended to ignore them. I mean, because if you're constantly thinking about it, constantly focusing on it, in fact, in the brain, you get this enhanced activity. Now, emotions alter a different activity in different parts of the brain, in these areas I call the limbic system. Here's the anterior cingulate cortex. Now here, again, this blob shows activation. Again, the same heat stimulus on the arm, but we put the person in a bad mood, and we get this stimulus, get this activation. You put the person in a good mood, you give them the exact same pain, and that activation disappears. So along with his feeling the pain feeling less unpleasant, we actually don't even have significant activation anymore in this same area, that we get quite a big activation when the person is experiencing the pain and he's in a bad mood. So the same stimulus, the same insult to the body, but depending on the mood state, you get more or less activation in these emotional parts of the brain. And I don't want to go into the details, but basically we found that if we look at these descending circuits, there's one circuit that seems to be important for attentional modulation and a different circuit that seems to be important for the emotional modulation. So even though they're both regulated by pathways in the brain, they're different pathways that are important for attentional modulation than pathways that are important for emotional modulation of pain. Now, I just want to say in real life, many things that you do or that your doctor does really affects attention and emotions together. So if you like to listen to pleasant music, if that seems to make your pain better, you have something that's distracting, you're listening to the music, but it's pleasant, it makes you feel good. Seeing movies that are fun and pleasant and are both distracting and put you in a good mood. Virtual reality is sometimes used, like in dental offices, or used experimentally, which is very salient, really attracts your attention, and is another way of changing both the mood and the emotional state and your attentional state. So here's a dentist office where the dentist has this man looking at this picture, and of course the picture is distracting, but it probably also can improve his mood, make him feel good, and has effects both on his emotions and his attention. So that's really the best when you have both of these systems engaged at the same time in a way that they're going to reduce your pain. So that brings me to placebo analgesia, that when you take a sugar pill, an inert pill, and you get pain relief. And you think, well, you just think that you're getting pain relief, or you're just crazy, or you just, whatever. But in fact, there's been many studies now, a lot of study of the placebo effect and placebo analgesia in particular, and find that in fact what happens when you have pain relief with an inert substance, it's really that you are engaging these psychological systems in your brain and activating these descending pathways that in fact reduce your pain in a real physiological way. Now, the placebo effect, there's two kind of components of the placebo effect. One is expectation. So if you're talking to your doctor and the doctor is somebody you believe, and he says, I'm going to give you this treatment and it's going to make your pain better, and you really believe and expect it's going to get better, that's a huge part of activating these systems in the brain. Then there's another part that's conditioning, that even if you don't believe, if say day after day you take a pill and it makes you feel better, and this is Pavlov's classic example of conditioning, where you have a dog, he sees the food and he salivates, and my dog does that every time I feed him, he salivates, and you do that, and then you pair something with that food, and every time you make a sound with the tuning fork and then give him the food, then all you have to do is do the tuning fork and he starts salivating. And you might see that with your own dogs at home, that when you're getting ready prepare dinner, before the food is actually in the bowl, when they see all the things that you normally do before you put the food in the bowl, you start salivating in anticipation. So part of placebo, let's say if you give somebody a pill that makes them feel better and they take it day after day, and then one day you looks and you see that the pill is expired and you take it anyway, and you think you really don't expect it to work, but just because you've gone through this whole same process, the same conditioning, you can have an effect even without expectation. So most placebo effect involves both, but expectation is the biggest component of placebo effect. And I just want to point out that now brain imaging studies show that when you get pain relief because of a placebo analgesia, we actually show, these red blobs show areas of the brain where there's reduced pain-evoked activity during the placebo condition, when the person experiences placebo pain relief, than when he's just experiencing the pain without the placebo. So it just shows that when a person feels that they have less pain in response to the placebo, the brain imaging studies are showing that what he's experiencing is exactly what the brain is telling him. He's not just imagining that he has pain relief. He really has, the activity in his brain is really reduced, and he's just experiencing what the brain tells him to experience. And during, like right when the person, say, takes the pill, it is during an anticipation that he's going to have a pain relief. If we look then in the brain at that point, we see that these descending modulatory pathways that I was talking about earlier, that one, particularly the one that we found is important with emotional state, is also activated during placebo expectation, showing that this placebo is working through these same pathways as emotional modulation of pain is working. And there's been some really nice studies showing that when you take a placebo, there's actual chemicals that are released in the brain in the same way. When you take like opiates, naturally occurring opiates are released in the brain. Like when you take morphine or another opiate, you are basically artificially putting into your brain these chemicals that are actually naturally occurring in the brain. And when you have placebo analgesia, you actually have a natural release of opiates in the brain. And you also have a natural release of dopamine. I have this because it's considered like the reward chemical in the brain. So dopamine, which makes you feel good, is like the feel-good chemical, and opiates, which is really the analgesic chemical, those two together are both released when you are experiencing placebo analgesia. And I'll show you these type of data where we can measure in the brain the release of the opiates or release of dopamine. And if you look at like different people, there's a lot of variability in the amount of placebo analgesia that different people have. So in this particular study in the laboratory, this line here shows the amount of analgesia, the amount of pain relief that the person is experiencing due to placebo. So the farther we go to the right, the more pain relief. And so you see that there's a lot of variation among these are individual subjects, and the amount of pain relief that the person, some people get no pain relief, some people get a lot of pain relief. But we see there's a nice correlation between the amount of pain relief that people get and the amount of opiates that are naturally released in their brain because of the placebo. So suggesting that this release of the opiates contribute to this placebo analgesia. And the exact same thing for the dopamine. The more dopamine that's released, the more placebo analgesia that people experience. So both of these seem to be very important chemicals in the brain that are released naturally. And what's very nice about this is when you release these things naturally, they only are released in the areas that are important for analgesia, and you don't get the same types of side effects that when you take a drug, when you're administering the drugs that lead to these activations. Okay, so that's it for placebo. It's an interesting concept because it's very important and it really works. But you know, there are ethical issues around whether or not doctors should hand you a sugar pill, even though we know that it works. I think in real life, many of the drugs that people take, they've been proven to be analgesics, and they have to go through rigorous tests against placebo. But then once they're out there, and if your doctor prescribes them and you believe your doctor, or you look at the advertisements on television that are saying they're so good, those things actually are helping, they're contributing, that your positive expectations actually contribute to a better analgesic effect. Okay, now here's another issue that we've studied in our lab that's kind of interesting and is related here, is how do psychological factors affect people who love or are caring for someone in pain? So psychological factors clearly affect the person who's in pain, but now we have evidence that they affect people who are caring for or who love someone in pain. And this came about because this study that was published in 2004, when we we talk about in our language, we say, you know, I feel your pain, and you do. When you have somebody that you love is in pain, you don't feel all of the pain, but you have certain components of the feelings that you may feel yourself. So in this study, they had young women lying in the MRI scanner and watching their husband or boyfriend experiencing pain. So the experimenters were giving a painful stimulus to the loved one, and the person whose brain was being watched was watching the other person getting the pain. And lo and behold, if you look at these limbic areas that I talked about, the cingulate cortex and the insular cortex, the emotional parts of the brain that are activated when you have pain yourself, they were also activated when you watched someone you cared about experiencing pain. Now the sensory areas were not activated, only these emotional areas. So which makes sense, because when you say, I feel your pain, you don't actually feel a sensation. What you're saying really is that you can share the emotional experience. And you're sharing the emotional experience because your brain is being activated in these emotional areas that are activated when you have pain yourself. As an aside, this study was published with all women, and when somebody asked them, well, why didn't you have men in your study? And it turned out that men didn't really do as well with this empathy thing as the women. So there's evidence. There's a lot of variation in empathy among people, and in general, women have more empathy than men, and so they tend to have these experiences in their brain more than you'd find with men, although it does happen in both sexes. So we were interested in, okay, if you have this phenomenon where you're watching somebody that you care about in pain, and you actually are activating these parts of their brain that are important for your own pain experience, how does that affect your own pain experience? Does that somehow make your pain experience worse because you're having a heightened response in these areas? So we tested this, and what we did is here's a thermo where we put a heat stimulus on the person's arm, and we tested their pain while they were watching a movie of just nothing, of just innocuous, bland things, sidewalks, bicycles, nothing that was emotionally stimulating one way or another. And then we did a manipulation to try to change the person's empathetic state. So we had them watch a movie of a person that was either telling a sad story about his girlfriend and how he was in an automobile accident with her and how she died in his arms, and it was very convincing, a very sad story, and the person was somebody that the participants were feeling much empathy with. And then another group of subjects, we had them watch a video. It's actually the same person, but this time he's telling a story about that he thought was very funny, about how there was a blind man that worked at the local convenience store, and he would go in there and he could figure out ways to put the change on the table and then move it around so that he would give the man less money than he was supposed to be given. And he thought that that was just fine because, you know, our society, we take care of these people too much. We give them too many extra things, and, you know, they don't deserve it. And he was just not a nice guy, and nobody liked him, and they didn't feel empathy for him. And when we measured their empathy, they were in a state of high empathy when they watched this guy, and they were in a state of low empathy when they watched this guy. Well, the subjects that watched this guy, they're different subjects that watched this one than this one. Then we had the people, we tested their pain again while they were watching this guy experiencing pain. So we had him putting his hand in painfully hot water, and he's holding in there as long as he can, and he's showing a lot of pain expression on his face. And when you're watching them, when people are watching him, then we test their pain again. So we test their pain when they're looking at something neutral, and we test their pain when they're looking at something when they're watching this guy, when they're in a state of high or low empathy. And when they do that, we find, it's not a very good graph, I apologize, but we find that the people that are in the high empathetic state, I don't know why this is coming up like this, but in the high empathetic state, they are experiencing these hot temperatures as more painful than the people in the low empathetic state. So it seems that having empathy, feeling empathy for someone who's in pain puts you in a more vulnerable position for feeling your own pain. So I don't know the long-term implications of this, but I think it's important for people that are healthcare professionals or people that are living with other people who are having pain, and it probably goes beyond just pain, but that when you're feeling a lot of empathy, this can have a negative effect on your own experiences. Now, I happen to like this picture a lot because this is a self-portrait by Frida Kahlo, and who is a Mexican artist who was in a bus accident when she was a young woman, and she suffered injuries that led to her having chronic pain throughout her whole life, which then led to her having depression throughout her whole life. And this is her picture of her pain. And it's interesting because many people who have chronic pain describe their pain in such a way of feeling like someone is driving nails into my skin. And people who don't have chronic pain have a hard time understanding these concepts because they just can't believe that somebody can be experiencing these types of things. But I think she did a really beautiful job of showing what many chronic pain patients experience on a daily basis. But I have this here to introduce this other concept that there is now evidence that long-term pain can actually affect a person's brain. So if you look at this brain here, this is the outer cortex, the top of the brain, and you have in the brain, you have areas that we call gray matter where the neuron cell bodies reside, and we have white matter where there's connections between neurons. But basically we find that there is a change in the structure of the brain when a person has had pain for a long time. And more particularly, these pathways, these parts of the brain that we know are important for controlling pain, that there are chronic pain patients that have changes in the gray matter, and particularly in these parts of the brain that are important for pain modulation. And so that the chronic pain patients have changes in the brain gray matter that might reflect changes in their ability to modulate pain. And the first study that showed this was done by Vanya Apkarian with back pain patients, and he measured the total gray matter in the brain, and he had patients where he called non-neuropathic chronic back pain patients. And these ones whose pain, these are drawings of localization of the pain, it was pretty much localized to their back with no radiation down the leg. And when there's nerve involvement, then you tend to get radiation down the leg, so he called this neuropathic chronic back pain. And he found that he had control subjects that were matched for age and education and other factors that could affect your brain. And he found that the control people had the most gray matter, followed by the back pain patients that had pain that was really restricted to their back, followed by the patients that had this neuropathic component and had the radiating pain. So they had the least gray matter, and the controls had the most. So there was a significant difference in the total amount of gray matter in the brain among these groups. And interestingly, one of the areas of the brain that had the biggest decrease in gray matter was this dorsolateral prefrontal cortex, part of this descending pain modulatory system that we have. And there's been now a number of studies. I just want to point out that you have lots of different types of chronic pain. Here's showing areas where there's this decreased gray matter in patients with chronic tension-type headache. We've done this with fibromyalgia patients, and others have too, and found similar results. Irritable bowel syndrome, neuropathic pain, basically every chronic pain syndrome that's been tested, you find that there are decreases in gray matter, and particularly, again, in these regions that are important for pain control. So what are the consequences of gray matter reductions? Well, I mean, besides maybe contributing to your ability to control pain, there is actually some indication that there is relationship with even other factors that attend chronic pain. Now, with many types of chronic pain, it's very well known in fibromyalgia, and fibromyalgia patients talk about fibro fog, but problems concentrating. But now that people are doing studies in other types of chronic pain, like back pain, there's evidence that there is people with chronic pain do more poorly on some cognitive tests, particularly tests that involve memory during distraction, so that they're less able to concentrate on something and perform a memory task when there is in the face of having some type of distraction going on. And one of the tests for that is called the ACT test. And in our fibromyalgia patients, it's not a huge effect, but it was significant that the fibromyalgia patients didn't perform as well on this type of memory test as did the matched control subjects. And when we looked in their brains, here's this frontal cortex is looking down the top of a brain, and this blue area shows where there's less gray matter in the fibromyalgia patients than in the healthy control patients. And you see that there's a nice relationship, a significant correlation between how well people performed on this memory task and how much gray matter there was in this frontal cortex. So suggesting that maybe some of this reduction in gray matter in patients could lead to some of these other symptoms that we find that attend chronic pain, such as changes in memory. Well, there is good news, and that's, okay, you look at this and you think, oh my God, this is, here, all these things are bad things are going to happen to my brain when I have chronic pain. But the good news is that when you can find ways to make the pain better, in fact, there's now evidence that these changes in the brain can actually be reversed. And here's a study from McGill, David Sminowitz and others here at McGill, but there's been several other studies now. It's like there's 3 recent studies, 2, this was with chronic back pain, and 2 with osteoarthritis. So here are back pain patients that, after having pain for years, ended up having successful surgical treatment for their pain. And the other 2 studies with osteoarthritis, after successful hip replacements, they found similar results. So this little blob here is the same dorsal lateral prefrontal cortex, important area for pain control. And what happens is that if you look pre-surgery, post-surgery of individual patients, that the thickness of that cortex increased. I mean, before the treatment, it was thinner than in the healthy controls. It increased with every patient so that it normalized, except for these 2 guys. 2 patients, it didn't get better. In fact, it continued to get worse. And these were the only 2 patients that the surgery, in this group where the surgery, in fact, did not improve their pain. Everybody whose pain improved also had a thickening of the cortex in this region. And there's actually not only this region, but other parts of the brain as well, including some of the sensory areas and the insular cortex, the somatosensory cortex, and this dorsolateral prefrontal cortex. But what was interesting is that if you looked at this increase, the change in the cortical thickness, how much it improved, and you correlate that with how much the people's pain ratings improved, you get a nice relationship. The more the pain ratings improved, the thicker, the more the cortex thickened, the more the pain ratings improved. And also when you're looking at the pain-related disability, there was the same nice relationship between the thickening of the cortex and less disability. So it really looks like the brain can start normalizing, and along with that, you get improvement in the pain and other measures. Now, many types of chronic pain, these are things like where somebody has a hip replacement. Well, most people with chronic pain, unfortunately, can't get surgical treatment that suddenly their pain is going to go away. But there are things that we find that people can do to help their pain that applies to all chronic pain. And a lot of things are lifestyle types of things, such as meditation, exercise of any form, yoga. In our lab, we studied yoga, but now there's good evidence of that just other types of exercise, or meditation. Yoga kind of combines exercise and meditation, but they can have a profound effect on reducing chronic pain. So what we did is we took a group of these were not pain patients, but just a group of people who had been practicing yoga for at least 6 years and compared them to matched controls. And we did a pain tolerance test where we had them put their hands in freezing cold water and see how long they could keep their hand in the freezing cold water. And the people who practice yoga could keep it in much, much longer than the control subjects. It was a huge effect on how long they could keep we had a maximum of 120 seconds, and most of the people with the yoga and they didn't know it was a maximum, but anyway, they kept it in until we told them to take it out, while most of the control people took it out in a matter of 20 or 30 seconds. And then we looked at the gray matter of the brain of these two groups, and we found that, in fact, the yogis, even though we matched them on every other variable that we thought was important, the yogis had more gray matter than the controls. Again, not a huge difference, but clearly significant. But what was interesting was that, again, if we correlated the amount of gray matter in the brain with their pain tolerance, the more gray matter there was, the better they tolerated the pain. And if we also correlated how much they practiced their yoga with the gray matter, the more they practiced yoga, the more gray matter. So it just suggests that you have a full circle, that these types of, people are now finding very similar things with meditation and other forms of exercise, that they have a profound effect on the brain and on pain perception, and particularly pain tolerance. So the take-home messages are: psychological state can have a profound effect on pain perception and associated brain activation. Placebo analgesia is not imaginary and involves release of opiates and dopamine in the brain. Empathy in a caregiver can have a negative effect on his or her own pain perception. And long-term pain can alter brain structure and associated cognitive function, but these changes can be reversed. And a positive lifestyle can help reduce pain and reverse changes in the brain. Thank you. And I want to put this slide up and turn it back over to Tanya.
Wonderful. Thank you very much. Catherine, that was a really great presentation. Very, very good. Some of the research statistics I hadn't actually seen yet myself, so it's very, very informative. Anne, do you have some questions that have been submitted?
Yeah, there are quite a few questions, and I'm sure there'll be more. Let me just start with this question regarding gray matter, that if one is taking painkillers, does this affect the rate in which the gray matter decreases? So if the pain is masked by painkillers, will the loss of gray matter be slowed?
Yeah, it's complicated because the gray matter is affected by many different things, and drugs themselves could have direct effects. But I think overall, anything that reduces the pain, whether it's pharmacological treatments or non-pharmacological treatments, the evidence would suggest that that should overall have a positive effect on the gray matter. Because you're not masking. When you take a painkiller, it depends on what you're either activating. They're either a peripherally acting painkiller that's anti-inflammatory, that's working on the input of, pain input that's going in the brain, or they're centrally acting, and they're working on these same systems that I showed you that are naturally activated by psychological state.
Mm-hmm. Thank you. An aspect of yoga and meditation is being mindful in the present moment and being aware of sensations and emotions rather than distracting yourself from them. Mm-hmm. Your earlier mention of research suggested that distraction from pain reduced the pain score. However, individuals such as those who practice yoga and meditation may be more in tune with their own pain and able to bear pain more. Can you come on?
Yeah, we have what I showed you here. We have a very expanded version of this. We're just getting ready to submit for publication, and it's true that what happened. But it's what we find that the yogis. We actually asked all these yogis afterwards how they controlled their pain, and when we did the pain tolerance test, and we asked the non-yogis as well. And the people that didn't do yoga, they would try to distract themselves. But when you try to distract yourself, it's like the saying, don't think about the pink elephant. And in fact, it's very hard to just try to distract yourself. And so they obviously were not very successful. The yogis, what they said they did is they would feel the pain, but they would reinterpret the pain. And we've actually done something very similar with hypnotic suggestions, where you feel the intensity of the pain, but you reinterpret it. And what we find is that in these emotional areas, we get a reduction in the pain processing. So they are feeling the sensation, but they're reinterpreting the sensation to have a reduced emotional effect. So they're reducing the emotional aspect, and that's why they can tolerate more, even though they feel the sensation. So they are altering their brain in a very positive way throughout the emotional systems.
Very interesting. This is a question that somebody asked that I had myself, and you did make some reference to gender distinctions, but generally is there a difference in pain perception that you've seen by gender?
Well, there's a large literature on this, and overall women feel more pain than men. And that goes along with the fact that many more women than men end up with chronic pain syndromes. So it's pretty consistent across the literature that women are more sensitive to pain than men.
Now, up at the, yes, that initial visual you had is a very strong one of the man hanging from the meat hook.
Yes.
Now, one of the questions was, if one chooses the pain, such as in that situation, are you better able to prepare for it and feel more in control of it? Yes.
There is also literature on controllability, and the questioner is correct in that when you have a sense of control over pain, it's easier to regulate it than when you don't have control over the pain.
Mm-hmm. Someone's asking, mentioning a lecture they heard by Neil Pearson, where he talked about attention, and that as therapists, this is a therapist talking, I think, we need to be careful not to distract patients too much, because there's a danger that the patients wouldn't learn how to cope with their own pain.
Well, I don't know what to say. I mean, I think if you don't want them to, I mean, the idea is to not to have pain, and if you engage systems in the brain through distraction that modulate your pain and reduce it, and in fact, we've even shown, in animal studies that even right when the pain signal is coming into the spinal cord, that the descending control from attention goes all the way down there and blocks or reduces the input just as it's coming into the spinal cord. So personally, I'm not sure about the question, because I think that your distraction is a way to engage important natural systems in the brain, and that's not a bad thing. I think that therapists, and that's something therapists should be aware of, in that things like keeping pain diaries. Well, it's good. Keeping pain diaries are good in order to understand what the triggers are and all the, and I think it's, when pain is not the same all day long, what are the things that influence it. But once you've understood that, my personal feeling is then kind of let that go, because the pain diaries are forcing you to constantly think about it. So they have a very important use, but then you also have to be aware to then to learn to let it go as well.
Mm-hmm. A question here about CBT and whether that can help with pain perception.
Yeah, well, CBT is that basically deals with all these things. It is a way that therapists can use to help teach patients to reinterpret, to change emotional state. All of these kind of basic factors that I talked about are incorporated into CBT, and there's now evidence, both just studies of people's pain perception, but also now there's some brain imaging studies are being done showing that in fact when you get relief, getting successful treatment with CBT, you are in fact engaging these systems in the brain.
Right. Tanya, feel free to jump in case I'm missing any questions here. Now, somebody early on asked if someone has a condition where basically they're looking at focusing, say a brain injury or head injury, who has pain, experiences pain from tasks such as concentrating or working on a computer. So maybe while they're doing the task and being distracted, they may feel a reduction in pain, but then afterwards it's in the end exacerbated. So I think they're wondering what
well, I think that anything
suggestions
that,
it would be.
yeah, I mean, I was using this kind of example about, when you're, but when you have pain related to a head injury, or you have migraines or things like that, that these are triggers that concentrating, looking at a computer screen, these things actually are triggers for your pain. Yes, that obviously if you're distracted so that you end up engaging in an activity that exacerbates your pain, that's not a good thing. I would agree with that you have to be aware of if there are things that trigger your pain, but you can imagine, but through your distraction allows you, maybe that was what the therapist was talking about, that you shouldn't end up engaging in activities that ultimately are going to lead to more pain because you're able to suppress it at the moment. So you should be aware of what the triggers are and avoid those things.
Mm-hmm.
No, that makes sense. That's a really good point, that a distraction is useful, but you have to make sure that you're distracting yourself with things that aren't going to make it worse in the long run. Yeah,
exactly.
No, that's very good. Now, I think we're just about out of time. I just want to extend one more time a really big thanks to Dr. Bushnell for being here with us. It was wonderful. Thank you very much, Catherine.
I'm not sure because I'm not seeing your screen, but I just wanted to make sure that everybody here, could go on the website for the Canadian Pain Summit website and endorse the Canadian Pain Strategy, where we're going to be going to Ottawa, and we're going to be lobbying to the government. Yeah, you have it pulled up here, great. And we would like to get as many endorsements as possible so we can get better relief for chronic pain patients.
Yes, and we as well are big enthusiasts for this Rise Up Against Pain Summit and for endorsing the pain strategy. The pain strategy
it's really
looks
easy.
really
You
great.
just click on that endorse and it goes right through, and if you want to then send a letter to your MP, you just put in your postal code. It composes the letter for you, and if you want to add anything to the letter, you can. If you want to go with a standard letter, it's really easy. It takes 2 minutes, so please do it.
I agree. You should definitely do it. And the web address for that, if you can't see it on your screen, is Canadian Pain Summit 2012.ca, and that's 2012. So definitely jump out there and do that. And thank you very much, Catherine, and we look forward to seeing you all at our next webinar.
Thank you.
Thanks, Catherine.